This webinar will focus on the important and critical role that primary care plays in our healthcare system. At the outset, let me thank the Commonwealth Fund and Arnold Ventures for their partnership on this issue, as well as our other healthcare work here at BPC. Once we turn to our panel shortly, if you wish to submit questions, you can do so via live chat on the YouTube or on Twitter using hashtag BPC Live. That's hashtag BPC Live. Now to the topic of this discussion. We know from extensive research that greater use of primary care services has long been associated with better health, better care, and lower cost. But we also believe that limited policies that are considered by the decision makers in support of primary care are not commensurate with the potential benefits. And unfortunately, primary care policy is often relegated to the back burner when it comes to the myriad other health policy issues Congress considers. At BPC, we believe that the positive outcomes of primary care services are foundational to the healthcare system, and unless those services are not strengthened, we will not achieve the broader goals of affordability, lower cost, better quality, and better outcomes. Over the last decade, BPC has consistently made recommendations addressing primary care. And maybe not surprisingly, we believe that payment reform is a key place to start this discussion today. Fortunately, this is a bipartisan issue, witnessed by the two congressional speakers you're going to hear from just in a minute, who have led efforts. These both members have led efforts in Congress to reform the Medicare payment system. Let me now introduce Representative Ami Bera. Dr. Bera had a 20-year medical career before coming to Congress in 2013, Democrat from the 7th District in California, and Representative Larry Bucshon. Before coming to Congress in 2011, Dr. Bucshon was a practicing physician and surgeon specializing in cardiothoracic surgery. He is a Republican from the 8th District of my home state of Indiana. And so I turn now for their remarks. We're beginning with Dr. Beshara.
My name is Congressman Larry Bucshon, and I represent Indiana's 8th Congressional District. Before coming to Congress, I was a cardiothoracic surgeon for more than 15 years. My time spent as a doctor has helped inform my thought process as a policymaker and has given me a firm grasp on the issues impacting patients and providers. I have long felt that some of the best ways to improve our healthcare system is through legislation that promotes value-based care. For our nation's healthcare system to become truly value-based, one that prioritizes patients and pays for services in a fair and appropriate manner, many reforms need to be made. Those of you who have been around for a while probably remember that in 2015, Congress sought to move toward a Medicare payment system that focused less on fee-for-service options and more on value-based care. We passed a piece of legislation known as MACRA, the Medicare Access and CHIP Reauthorization Act, with this intent. Unfortunately, it has become evident over the last several years that reforms to MACRA are necessary. Under MACRA, the Centers for Medicare and Medicaid Services have a lot of power to determine payment through its annual publication of a physician fee schedule. Many members are interested in knowing more about how CMS makes decisions about the physician fee schedule and what Congress could do to increase its effectiveness. To that end, last fall, Representative Ami Bera of California and I led a group of 8 bipartisan members in soliciting feedback from providers and other stakeholders to address this issue. Our request for information received more than 130 responses, and we are in the process of going through them and sharing findings with the committees of jurisdiction. I am also working with the Energy and Commerce Committee, on which I serve as the Vice Chair of the Health Subcommittee, to ensure that Republicans prioritize the issue this year and use our process of holding hearings to examine it. One thing is clear: the status quo is not sustainable. If we do not implement changes, we will continue to face an outward flow of physicians. This will lead to greater shortages than we face already, particularly in certain geographic areas and among certain specialties. Another priority of mine, which would improve the healthcare experience of providers as well as patients in the Medicare Advantage program, is passing my Improving Seniors' Timely Access to Care Act. Nationally, approximately 29 million seniors receive their health insurance through Medicare Advantage, including over 500,000 Hoosiers in my home state of Indiana. This bipartisan legislation would help streamline and modernize the prior authorization process within Medicare Advantage plans by removing outdated practices, allowing doctors to spend more time with their patients. Inefficiency within the prior authorization process creates unnecessary paperwork, lag time, and hassle for doctors, which can delay life-saving procedures for seniors. This legislation passed out of the House of Representatives last year, but did not move in the Senate. I am working with my fellow co-leads, Representatives Del Bene, Kelly, and Barra, to get it to the President's desk this Congress. Finally, I'd like to remind folks that even though there is still much work to be done, there are already some really successful value-based care initiatives operating today. An example I am familiar with as co-chair of the Bipartisan Kidney Caucus is the End-Stage Renal Disease Quality Initiative Program, which promotes high-quality services in renal dialysis facilities. This is one of the first initiatives that Medicare has put forward and has revolutionized the way CMS pays for the treatment of patients who receive dialysis by linking a portion of payment directly to the facility's performance on quality of care measures. I want to close by saying thanks to each of you for participating in the healthcare advocacy. Members of Congress rely on stakeholders like you to learn about the issues we need to address. We could not do it on our own, and your time is very much appreciated.
Hi, I'm Congressman Ami Berra. I represent Sacramento County. I'm also a primary care internist, so I want to thank the Bipartisan Policy Center for this forum to talk about primary care payment reform. Yeah, the move to value-based care is incredibly important because what it does is it starts to incentivize efficiency and cost and quality. And that's what we should be doing, because at the end of the day, this is about taking care of our patients, and we should want to incentivize and reward value-based care that delivers the highest quality and most efficient care. So again, Bipartisan Policy Center, thank you for the work that you do on this important issue, and I hope you guys have a great conference, and let's go primary care physicians.
Thank you, Congressman. I want to now turn and welcome and introduce our moderator for our discussion this afternoon, Dr. Ishani Ganguly. Dr. Ganguly is an assistant professor of medicine at Harvard Medical School and a practicing internal medicine and primary care physician at Brigham and Young Women's Hospital. Her research focuses on primary care payment and delivery. Finally, unfortunately, I have to say that Adam Bowler had last minute could not join us today because of an unexpected conflict. But we are pleased to welcome another Adam Myers, to the panel, now with the Blue Cross Blue Shield Association, a family practice doctor and former primary care leader at the Cleveland Clinic. So Dr. Ganguly will introduce the other panelists, and I turn it over to her now. Doctor?
Thank you so much. So as we've heard, primary care is facing a crisis in the U.S. Systemic underinvestment in primary care has contributed to workforce shortages, capacity limitations, and declines in primary care use and access. And these challenges, in turn, have compromised the well-established benefits of primary care, including lowering spending, morbidity, and mortality. Primary care payment reforms have the potential to address these concerns, right? So currently, most primary care clinicians and practices are paid fee-for-service for just a subset of all primary care work. And this approach is fundamentally at odds with the goals and functions of primary care. Fee-for-service payment also contributes to pay inequities within primary care and between generalists and some specialists, which undermines primary care capacity as well as workforce recruitment and retention. Value-based payment reforms may tackle some of these issues, though its impact in future is uncertain. And so to dig into these issues further, I have a fantastic group of panelists this afternoon. Bill has introduced Dr. Adam Myers, and I'd like to introduce the rest. We have Dr. Mai Pham. She is the president and CEO of the Institute for Exceptional Care. She is also the former chief innovation officer of the Center for Medicare and Medicaid Innovation. Here she was a founding official and the architect of Medicare's foundational programs on ACOs and primary care. She's also a general internal medicine doctor by training. Next, we have Dr. Bob Phillips, who's executive director of the Center for Professionalism and Value in Healthcare at the American Board of Family Medicine. He is also co-chair of the NASM report on implementing high-quality primary care and a practicing family medicine physician. As a reminder, we'll have time for audience questions throughout the session and at the end of the session as well. You can submit questions using the live chat on YouTube or on Twitter using the hashtag BPCLive. All right, without further ado, I'll direct the first question to Dr. Phillips or Bob. Bob, give us an overview of why primary care matters so much and why payment is so foundational to the value of primary care.
Thanks, Ashani. So our report came to the conclusion that the evidence is still incredibly strong that primary care is the only part of the healthcare system with evidence for improving health equity, and particularly for life expectancy, and that it should be a common good, meaning that anyone who wants access to it should have access to it. The report said that primary care is being starved of resources and that it has declined in terms of its the commitment of total spend to primary care, so that we're down to 5 to 7% of all of the spending in the healthcare system going into the sector that provides more than a third of all care and is where most people turn for their trusted health relationships. So payment becomes fundamental. We cannot starve the sector of the healthcare system and expect it to deliver on those health equity functions that it's able to.
Makes a lot of sense. So you're referring to the total pot of money. Can you speak also to the idea of how payment is delivered to primary care practices and physicians and where you see the challenges there?
Sure. So our objective under payment, which was the first objective because it is so foundational to achieving the others in the report, is that pay for primary care teams should be for caring for people, not for delivering services. So fee-for-service, as you talked about, is particularly toxic to this environment because it doesn't allow us to really focus on the relationships and on the population health functions that we can do. So we talk in the report about hybrid models that have a high proportion of capitation payment so that practices have payment up front that allows them to flexibly address the needs of their patient population. And perhaps with some fee-for-service maintained so that there are certain services that are certainly delivered, but that we should work increasingly towards that capitation model that not only brings risk, but brings accountability and brings capability of primary care to do what it does best.
Thank you. Adam, I wonder if you can build on that and talk a bit about how value-based payment models have played out in the clinical settings that you work in. What does it mean for clinicians? What does it mean for patients?
Yeah. Ideally, we have a situation in the ideal world where teams are empowered and equipped and day to day provide the best necessary care to people who are entrusting them with their lives. However, there's a certain reality in life and in human nature, and healthcare is no different. What gets paid for tends to occur, and what gets paid for more liberally tends to occur more often. And so if you think about that, right now, volume is what gets paid for, not outcomes. Our current fee-for-service pay paradigm pays for encounters on a transactional basis. Each encounter has a relative weight. Productivity for physicians and teams are measured in RVUs, and it's very, very transactional. Even many of our value-based payment programs are really layered on top of a fee-for-service rubric. And we're getting the predicted outcomes that we would imagine from that. Doing more pays more, therefore more gets done. And it's focused on the more and not the outcomes. I like to think about it almost like value-based care. Really, in my mind, it should be sort of changed to where it's values-based care, meaning how are we paying differently for the things that we say we value and the outcomes that we value. If we value health rather than simply the treatment of disease, well, how are we paying differently for those outcomes? If we value for relationship-driven whole person care rather than a transactional approach, how are we paying differently? And I'll give you sort of a real world example of how this plays out. I, in a former life, was chief of population health at Cleveland Clinic. And in that role, I had all of primary care from
pediatrics to geriatrics. I used to call it twinkle to wrinkle, sort of reporting up through me in that capacity. And when I first started there, we had very little of our payment structure in any sort of value-based payment arrangement. Over time, I met with our teams and said, let's envision a different sort of care. Let's envision prospective rather than reactive, relational care, team-based care. But it was pretty clear that given the fee-for-service paradigm that we couldn't really do that. So a payment change was needed. So we moved rapidly into this hybrid type of arrangement that my colleague just described, where we had capitation for primary care. When I started, 0% of payments were in capitation. When I left there, about 70% of the payments within primary care were capitated. It freed up for true team-based care where people could get off that every 15-minute sort of pace of seeing a patient every 15 minutes and prospectively reach out to patients, not just based on whether they'd reached out, but looking into the record and say, who needs our help rather than who's on our schedule? And it was a game changer. Outcomes improved, relationships with patients improved, the engagement of our care teams improved. So I think all around changing, not just as you described, what percentage gets paid toward primary care, but how that gets paid, whether it's transactional or whether it's maybe more upfront and longitudinally oriented.
Thank you, Adam. I think a key takeaway from your comments is also this idea that it's how payment is made, but then how that translates into workflows and giving clinicians the space to do that outreach, right? So, when I go to my clinic session, I'm booked back to back. I need to have some dedicated time to be able to work with a population coordinator in my clinic to reach out to patients with high blood pressure and see how I can help them reduce it and things like that. So it really, it boils down to these details that trickle down from the payment decisions that are made in Congress.
Absolutely.
Thank you. And so we're getting some questions from the audience. Before we get to that, I also want to give Dr. Pham a chance to comment a bit on the policy implications here. I wonder, Dr. Pham, what you would say about how Congress can think about reevaluating MACRA in light of these challenges and changes to physician payment that may be effective to improve primary care.
Yeah, thanks, Ashani. I think it does require some unpacking. First of all, as I was listening to Adam, the analogy in my head was, what if we were to pay parents for the work that they do raising their kids? Would we pay them $5 to give one child breakfast and then $6 to give another child lunch? Or would we want to give them the resources they need to tailor the kind of parenting and supports that each individual child would need? That's really the kind of payment structure and environment that we need to give primary care clinicians to do the very complex things that we're asking them to do. We are not asking them to do a colonoscopy that has a straight algorithm. That is very different from doing the integrative work of figuring out, here's a person with a whole bunch of different complex clinical issues. What is the most efficient, meaningful way for me to help solve their problems? So I just want to anchor that a little bit. In terms of policy opportunities, especially as it relates to MACRA, I think it's important to go back and remind ourselves that MACRA was a replacement for a previous policy called the Sustainable Growth Rate Policy, which had imposed upon the Medicare fee schedule a requirement that every year, if total spending on what are, physician and provider services exceeded a certain benchmark, that the following year, all those rates would need to be squeezed down. Congress actually almost never allowed that to happen. And so prices just kept increasing. And so MACRA was an attempt to say, well, the prices from now on in the physician fee schedule will increase based on how a physician, a practice performs on quality and the degree to which they participate in value-based payment models. I think those are very well-intended, thoughtful goals. for the legislation. But the reality was that that legislation was always constrained by the pay force. And as a result, what happened was that the rewards that were offered, so your prices in fee-for-service would go up more if you were in more meaningful value-based payment arrangements. But those bonuses started to dwindle over time. And MACRA did nothing to change the underlying fee schedule to a great degree, right? The performance rewards were actually quite small relative to the total revenues that a physician or a nurse practitioner might receive from Medicare. And as a consequence, it didn't really change behavior. So as we go forward, I would encourage legislators to consider the fact that value-based payment will never, ever reach its full potential. It will always run into the brick wall that is how attractive current fee-for-service is. Because we've talked here about all the ills of fee-for-service, but economically, fee-for-service is actually, as it's currently priced, very lucrative, not for all providers, but for some providers. And it is that lucrativeness that makes it very challenging to get remaining providers into value-based payment. It also limits how attractive Medicare, CMS can make a value-based payment arrangement because they can only compete so much with the lucrativeness in fee-for-service. And when we talk about that lucrativeness, we have to recognize that that is not uniform across all the services in fee-for-service. There are many services within the fee schedule that are extraordinarily lucrative. And there are other services, like many services that primary care clinicians offer, that are grossly underpriced. And it is those distortions in the relative prices that result in the downstream impacts of clinicians in training deciding that it's not viable for them to go into primary care, especially if they have loans to repay. But I think even more importantly, once you're in practice, you know, if you have a lot of excess revenue, you can do things like hire another patient educator or partner with a social worker to support your patients, prevent that next death of despair. If you don't have those resources, you can't do that. And so the implications of the pricing distortions in the fee schedule really, really hamstring what primary care can achieve and puts the population, frankly, at risk. And so the path forward, I think there's some clear actions that Congress could consider. One, you could consider making a whole break from history. And rather than insisting that CMS govern fees for all physician services in one fee schedule, set up two fee schedules. Set up one for procedures and one for what we would call evaluation and management services. That's the cognitive work, that's the visits that don't require equipment and procedures, right? Splitting up the fee schedule that way would give CMS a lot more flexibility to adjust payments for primary care without necessarily affecting payments for other services, which is often where the political pushback comes from. A second opportunity, as both Bob and Adam mentioned, is to give CMS new authority to create hybrid and capitated payment models for primary care. CMS does have some existing authorities to do that in a limited way, and it would be good for Congress to encourage CMS to use those authorities, especially in the Medicare Shared Savings Program. But to reach the majority of primary care clinicians would require an act of Congress and new authority for the agency. And with that new authority, the agency can also implement more novel ways to adjust payments for primary care to reflect the levels of need that the populations they serve have, and to hold them accountable for outcomes that are really meaningful. You know, I think we should drop the notion that just giving someone an aspirin after an acute heart attack means that you are delivering quality of care. delivering quality of care is actually you are meeting that patient where they are starting from, and you are giving them what they need and helping them get to their goals. And so there's an opportunity to be really innovative there. Second, I would point to the opportunity to look at the fee schedule prices themselves. There is a lot of known waste in the fee schedule. There have been many, many studies pointing to specific services that are overvalued in terms of their prices. And it's also become an incredibly complex juggernaut. Over 8,000 codes to bill with, which don't necessarily reflect meaningful differences across so many different services. No one really needs 21 codes to bill for a colonoscopy. And when you have that much complexity, really on the ground, all it creates is an opportunity for billing games and for practices to optimize how much they get for a given procedure, not reflecting at all the value that that has to the patient or to Medicare or to taxpayers. And so there is an opportunity to empower CMS to grossly simplify the fee schedule, cut it way down to maybe just a few hundred families of codes that together can have a single billing amount, and grossly, frankly, eliminate a lot of administrative burden for clinical practices that way as well. The combination of those things and standing up a new hybrid payment model would go a long way. But if it is just a one-time set of actions by Congress, it won't be sustained. What is really important is for Congress to empower CMS to continually and scientifically update the fee schedule with accurate data based on new data collection that the agency conducts, and that is not conducted by vested interests like professional medical associations or others. It really needs to be an effort that is as impartial as possible and that can take into account the policy priorities for the country. So I would throw those out, Ashani, as some starting points for discussion.
Thank you, Mai. That was a really clear-headed and an actionable set of solutions, and I think there's a lot to unpack there. I wonder if we can I've gotten two questions on the issue of people going into primary care. So the pipeline concerns, and Katila Farley asks, very few physicians going into primary care, do we need to focus on solving this issue? Bill Hoagland mentions, do med students recognize the payment system and as a result specialize, and leading to a reduction in primary care professionals? I'd love to hear others' thoughts on this in the panel, specifically around the role of payment in workforce recruitment and retention.
In the report, we point out that this is in fact happening, that our clinicians are very sensitive to these price issues, and students too. More than a decade ago, we showed that the increasing gap in income between primary care clinicians and subspecialists reduced the likelihood of a medical student going into a primary care career by half. And the American Board of Internal Medicine just last year published a study showing that we're down to 13% of general internists going into primary care, choosing to subspecialize or to become hospitalists because, not strictly because of the income, but because of income and their existing debt and control over their lifestyle. It's a combination of things, but the fundamental problem at the heart of all of that is the payment differential. Mm-hmm. And it's driving 15% of primary care family physicians into hospitalists and more lucrative roles as well. So it is toxic. The report points out also that nurse practitioners and physician assistants are leaving for more lucrative opportunities. We're down to less than 24% of PAs in primary care and less than a third of nurse practitioners. So it is just creating a toxicity to a workforce that's already eroding, particularly in rural and underserved areas. And there's a direct linkage between that and the growing health inequities, particularly in rural areas.
Yeah, I guess I would. Oh, sorry, go ahead. I was going to say I would add to Bob's point that improving payment for primary care is is not just about having a more competitive salary. It is also about the resources that those practices have in order to make their work manageable. If you are in a 2-3 person practice and you have to do everything, you will do nothing well.
Yeah.
But if you can have the supports to help educate the patient, do the social risk factor screenings, help direct them and get them referrals to what they need, help them make appointments, that is a whole different way to live as a primary care clinician. Most clinicians who go into primary care or medicine generally aren't looking to make the most money possible, but the balance of their salary versus how impossible it is to do what they think they should be doing for their patients is not tenable.
Back in 2009, a study came out of North Carolina that looked at an average family physician with an average panel of 2,500 patients and said for those 2,500 patients, the amount of time that it would take for a single practitioner to implement the best practice in most of their lives was 21.7 hours a day. And that was prior to meaningful use and layering on top the EMR. University of Chicago just sort of replicated this, and they came up with a number closer to 28 hours in a single day. So our fee-for-service paradigm doesn't reimburse primary care offices and teams enough to change the way that that's done, to really focus on team-based care. And that's part of why I made the changes I did at Cleveland Clinic. We realized that individual practitioners feeling like they had to meet every patient's needs by themselves was just not sustainable. And they can't do it well. And as Mai said, you essentially have teams that are starved for resources and they just can't meet the needs. So we found that getting prospective payment allowed the teams to decouple from transactions as their mode of payment and say, we can now hire pharmacologists to be in our practice. We can now hire behavioral health social workers to be part of the teams. And we can offload some of this work to the right people on those teams and empower the physicians to simply do the things that only they can do. And it was an absolute game changer, but essential for that was a change that we initiated ourselves in the payment paradigm. The teams are starving for resources.
It's really well said. I think in some ways, specialist practice is easier. You get to focus on one organ. In primary care, patients come to us with everything. We're their everything doctor. And so this is something that, I precept residents in clinic. They observe, they're smart, they're making decisions based not only on the financials, but also just on the current state of work. And I think it's a hard balancing act for those of us who interact with trainees to sort of sell the joys of primary care and the value and the future of primary care with the realities on the ground. And I think payment reform has the potential to address that in so many different ways, as the panelists have alluded to. One point it might be helpful to make here is that as many of you know, in 2021, Medicare changed the E&M in a payment reform for the E&M visits with the stated goal of trying to increase money for primary care. Our team did some research on this in a paper that we can share that came out in JAMA, finding that the payment increased for across the board, right? So E&M visits are done not only by primary care physicians, but also by specialists. And the end result was that family medicine and internal medicine did see an increase in payments over the year, but so did other specialties. And at the end of the day, the payment differentials was about $824 between the groups, so about 0.2% of the existing pay gap. And so it really speaks to this idea that Mai describes so beautifully about it can't just simply be making tweaks to the fee-for-service system. We have to think bigger. We've gotten some really great questions from the audience. I'm going to turn next to the question about RUC. There's two, one from Divi Upadhyay. Dr. Pham, if you can comment on the role of RUC and the price distortions in the fee schedule. Will they agree to splitting the fee schedule? What will the role of RUC and hybrid payment mechanisms be? And relatedly, from Ron Adler, when and how are we going to challenge the power of the RUC, which has created and sustains the price distortions that are so persistently influential?
Right. So I would, I would reinforce Ron's comment. I mean, I might put it in a more balanced manner in that the RUC does its best to update prices, but it's driven by, its recommendations are driven by data collected by specialty societies themselves. And the more funds that a specialty society has to conduct that data collection, the more advantage they have in requesting higher prices. And primary care is not in that position. And so you end up in a very, very bad feedback loop. I'm a very pragmatic gal. And so from my perspective, while the RUC is a private organization and CMS is not required per se to follow its recommendations, at the moment, CMS has no alternative to turn to in terms of systematic data on the costs of service provision, right? Those input costs. That is what Medicare is authorized to base prices upon, absent an act of Congress. So what I mentioned before in terms of the legislative opportunity to give CMS new authority to establish an advisory panel that would help review data and also give the agency the resources it needs, which is not very much, to collect its own data and make its own inferences about input costs and hence pricing. That is not about doing away with the RUC. That is providing an alternative and additional source of information for the agency to consider as it makes its not only pricing decisions, but payment policy decisions more broadly. That advisory group can also advise on the structure and content of a hybrid model, for example. It can advise on value-based payment arrangements, for example. This is, I think, as we envision it, a much more competency-based, technical, hands-on advisory group than, for example, the PTAC, right? This has to be a group of experts without vested interests who can really push CMS to think rigorously about the technical aspects of doing this and hold CMS, help Congress hold CMS accountable for adhering to legislative policy priorities. That I think is my answer to the RUC is after 30 years of watching political battles, I'm not sure that that's a constructive way to spend time. If the RUC wants to continue making recommendations, it can do so. And perhaps the RUC will find its way to making more balanced recommendations. But that can happen in parallel to development of a healthier structure of 2 fee schedules, hybrid model, and reassessed prices within those fee schedules.
Thank you. Comments from others on the panel?
Shani, I would just say that our report recommended that the RUC be moved into an advisory function, and instead of having such influence over the current policy environment for setting payments, as much as Mai said. So I think our report would endorse what she said.
Bob, another set of questions that has come up has been around how physicians experience value-based payment. Sadra Reagan asks, how do we give time and payment to providers and staff to learn the QI methods to increase quality care and value? It's seen as another burden, especially when different insurers have different priorities. And relatedly, Laura Russell asks, how do we achieve payer alignment? Insurers have their own programs that individual providers participate in, which can create administrative burden and different quality incentives. So this issue about having to just spend most of your time trying to address what payers are asking for and especially quality measures. I'm curious if maybe, Adam, this is a good question for you, but I open it to the group.
Sure. When I was on the provider side in practice, I was credentialed with probably 20 or so different payers at any given time. There were sub plans within them. And as the question alludes to, sometimes what seems like it would be measuring the same thing, meaning how are we measuring the success of diabetic control, would be simple and straightforward. But in reality, out of those 20 different plans that I participated in, there were probably as many unique ways or iterations or inclusion or exclusion criteria for measuring success in managing diabetes. So I think unifying the measurement process to fewer and more meaningful measures, but having to be unified across payers from an outcomes perspective would be critical to make some sense of this as we move forward. Completely agree with that. And as far as how do we inform teams about quality improvement and change the payment paradigm in such a way that quality improvement processes and the training to embark upon that can be embedded into practice, I really think, again, it boils down to upfront payments that allow the teams to be thoughtful, to pause, to work together as a team prospectively about how are we going to change our workflow to reach out actively to people who need us, and have panel management time. You literally start with doing panel management time, query your panels, see who needs our care, and reach out. That is a quality improvement process rather than the reactive approach of just taking care of the people that are on your schedule. And I really think personally that changing the payment paradigm to that more hybrid approach will facilitate that naturally.
Adam, I'm going to push you on that first point. So how do we actually operationalize that idea of aligning payers on quality measures?
Yeah,
what are those measures going to be?
Yeah,
it's not going to be a simple solution. I'm curious what others think.
Yeah, I don't have the answer to that one. I would say, I think there is an opportunity for the federal government to step in and sort of unify the approach to some of these things. But I'd love to hear from other panelists if they have different ideas as well.
Well, I'll take that question first, but I want to back up to the value-based payment question, Shani. The first is that there are entities like the Core Quality Measure Collaborative that was designed to try and create alignment across payers on core measures, on things that all of them agreed were important. And that process has largely focused on improving measures, not on getting alignment. And I think that's where we need to make the shift, is how does that group of payers make decisions about what they're going to use together? The second issue is, and we have an entire chapter in our report dedicated to this, is that we're not measuring what matters in primary care. We are driving primary care doctors to distraction. And in fact, in the most recent efforts to align measures, we've taken an entire set of measures that are primary care's burden. And it drives us to distraction. Not that those measures are bad, but it drives us to distraction when the most important value-based measures for primary care, continuity about relationships over time, and comprehensiveness, the ability of our team to meet most of the needs of patients, are the most potent measures for reducing costs, reducing utilization, and improving life expectancy. But neither of those have made it through the gauntlet of approval for primary care to use them. And it doesn't then drive health systems to reinforce those critical functions of primary care. So we have just enhanced burden. We have not really focused on the things that primary care can deliver exceptionally well, that reduce all of the things we want to reduce and enhance the things we want to enhance. And getting the measures that matter will be critical for us.
Yeah, so I want to underscore that point from Bob as well and say it is my belief that I don't think you need more than half a dozen measures ever, especially if they are outcomes measures. In addition to those elements of primary care continuity, comprehensiveness that Bob mentioned, I would vote for something universal like a goal-oriented metric. Did you document what my goal is? Did you document where I am starting from? How far along are we from where I'm starting from to my goal? We got to goal, Yahtzee, right? Yeah. That I think is the type of thing that clinicians, if you get them in a quiet moment, will tell you, just reward me for solving my patient's problem, please. Yeah. And so, but then back to the pragmatic question of how do we align payers? I think we need to recognize that in a country that worships employer-based insurance, or at least is not willing to let it go, there will always be limits to how much alignment one can get, because employer-based insurance generates a competitive market where payers are trying to differentiate themselves. And one of the ways that they try to differentiate themselves is, oh, we've got a fancy new thing that we're doing in quality. And so you spin and spin. That said, there are collaboratives of payers, and policymakers can amplify those, right? Congress can and CMS can put out an incentive, either through ACA exchanges or through Medicare Advantage or otherwise, for health plans that participate in measure alignment initiatives, right? State insurance commissioners may have a role to play, for example. So a lot of this, unfortunately, will be kind of hand-to-hand combat, but there are efforts out there.
I love what you emphasized about sort of fewer functional outcome measures that matter and matter most from the patient's perspective. I love that.
Building on this, Howard Haft has a question. Are there any policy tools to compel commercial and state Medicaid payers to adopt sufficient hybrid payments in harmony with Medicare?
Yes, I think it does require political will, but the tools are there. Plans want to be eligible to participate in Medicare Advantage. They want to be eligible to participate in ACA exchanges. And so there are conditions of participation that Congress and CMS can consider leveraging. Medicaid states want the flexibility to experiment with their various waivers. That is another point of leverage where CMS can say, well, okay, we'd also like you to prioritize X, Y, and Z. And the expectation is, the floor is that Medicaid is going to move to a hybrid payment model. Now, it's important to note that telling states that is one thing, and states telling health plans to do that, states offering health plans a hybrid model is another thing. In fact, many states now offer Medicaid health plans full capitation. But then what happens is the health plans turn around and do not transmit that capitated payment structure down to the clinical practices and hospitals. They pay fee for service. And so really where you want the policy focus is in requiring intermediary health plans, whether that's in Medicare Advantage or in Medicaid managed care, to set up those structures in their provider contracts.
And then to ensure that there's enough penetration of those contracts so that a given physician has majority value-based care, right? And enough incentive to follow those.
Correct.
Incentives.
Correct. And it is always dicey for government to require that, because the dynamics in every healthcare market is different. And in some markets, health plans do not have the leverage to demand that their providers receive a hybrid payment. But then in other markets, providers who want that hybrid payment don't have the leverage to request it. So you would need to put on some guardrails to allow for exceptions, but setting the expectation and perhaps offering positive financial incentives to health plans who manage to do it, that would be a great first step.
So building on this idea, we've gotten a few questions on the role of other clinicians within a capitated system. So from Carla Cobb, how do you suggest balancing capitated payments with fee-for-service for other specialized disciplines in the team, like pharmacologists and behavioral health specialists? And M.A. Smith asks, how do we compensate non-physician clinicians as extended primary care team members?
Yeah, I jump in at the clinic. The way that we did it was we negotiated, and I'll tell you, it was a little difficult to do it, but we negotiated with payers by the ones this capitated arrangement. And then we built the teams that we felt like we needed to meet the local needs wherever our offices were placed. Some places needed a pharmacologist on site, some places based on the patient mix that they had. Some just needed one available for consultation, maybe virtually. Once we had the overall PMPM set for the primary care space, we weren't that worried about, okay, how is the pharmacologist getting paid? Is there a fee schedule for them? How is the licensed practice counselor or behavioral health social worker getting discreetly paid? Is there a fee schedule for them? Our focus was, let's just get paid as a team for doing the right thing for the patients that we have, and then not worry directly from a payer perspective about whether all of the touches that we think are necessary are directly compensable. And that's the way we did it. We essentially decoupled the individual productivity from the overall fee schedule, and then transferred that appropriately to our team members, the revenue appropriately based on just salaries, et cetera.
Thank you, Adam. Steve Elson asks, has anyone seen effective ways that are attractive to clinicians to share the risk on total cost of care with primary care doctors in a capitated model?
I'm sorry, for who to share the risk?
For clinicians, for primary care doctors themselves.
Oh, so I want to clarify that when at least I talk about hybrid models and primary care capitation here, I am not talking about early 1990s managed care capitation, in which primary care practices were responsible for the totality. They were actually taking insurance risk on the totality of spending that a patient might require, or a population of patients might require. That's not what we're talking about here. We are talking about primary care only being at financial risk for the revenues that that practice would receive anyway, right? Historically, based on historical numbers, with an increase in prices, we hope. I would argue by at least 50%, but I'm no longer in government, and so I have those First Amendment rights. So in this vision, the primary care practices would not be at risk for, say, what a cardiologist does outside their practice, or whether that patient ends up in the hospital. They may have some performance risk for that hospitalization, right, if they're being measured on avoidable hospital visits, but that is not going to, they're not responsible for paying those downstream bills, except for their own team members. So that's an important distinction. And then, how should a practice compensate its team members? I would say, I would remind us that Jamie Robinson from UCSF used to say the three worst ways to pay a clinician are capitation, fee for service, and salary. And so my intuition from that is that really you should look at a mix of all three, because then you have a chance of fiddling with the dials, more on this thing, less on that thing, to get to the right balance where the incentives are such that the clinician can stop thinking about where the money's going to come from and just focus on the work.
Wonderful. We have just about 4 minutes left. The time really flew. I want to turn our attention in the last few minutes to a set of questions that has come up and we were hoping to discuss around sort of new entrants in the market. So I wonder if we can comment on the role of retail clinics, the role of private equity and employers, and what they're doing to the primary care ecosystem, and so what we are hopeful for. How can they contribute to improving the status of primary care in the U.S.?
Well, I'll just jump in. I think many of these solutions have arisen because there were unmet needs within the traditional healthcare ecosystem. And so one is, what can we learn about the unmet needs so that we can find a way to embed that into the more traditional healthcare ecosystem? Why do I say that? Because I think sometimes there's a potential for the new entrants, while they might be serving a very discrete need, that can also sometimes, not all, lead to significant increased fragmentation. So I think that fragmentation is a problem that we need to sort of counter as we move forward. And the other thing that I think it's important to recognize is a lot of the entrants have come into certain discrete areas of healthcare because there is specific revenue there to be garnered. And so we have essentially incentivized new entrants to come into the ecosystem. And my hope is that we can transform the payment approaches that have created that incentive in such a way that the payment actually enhances outcomes rather than just simply documentation for the outcomes that have already existed.
I completely agree with that. I think they are serving a need of insufficient access to care in many places, and particularly for acute care needs where someone can't wait several days to be seen. But that is also emblematic of the problem we've created in primary care, where there's just not enough capacity.
Right.
And it winds up fracturing relationships, and it also leads people to believe that primary care is simple rather than foundational, and that what someone can get in an urgent care clinic is the same thing that they can get in a sustained relationship with a primary care team. And that is a real problem. But I acknowledge the fact that in my own area in Northern Virginia, trying to get a neighbor into a new care relationship because her physician had gone into a concierge practice is happening all over. And it took me a week and 15 different outreaches to find her a new primary care physician, because so many people's panels are full. They just cannot accept new patients. So that is a separate problem that has its own policy solutions. But in the meantime, we're fracturing care and fracturing healthcare relationships, and it's not going to end well.
And I think we also need to remember what policy concerns are top of mind for us right now. There is a mental health crisis. There is an opioid epidemic. There is an epidemic of deaths of despair, mortality, or life expectancy has plateaued for Americans. Americans in midlife are dying sooner, which is crazy for the world's richest country. And I don't think that private equity and primary care is going to solve any of those problems, because for the most part, that venture capital is not chasing populations that need the most help. They are not searching out the most complex patients possible, right? And so you can frame it however you want, but the reality is that the top of the license, when a primary care clinician is practicing at the top of their license, they are solving the most complex problems in clinical care. And that is what we have divested from. So where there is a lot of money flowing in, that is not where it's flowing in.
Thank you all for your excellent comments. We've reached the end of our time. Thank you all to our audience for the excellent questions. Have a great afternoon.